This is a case of a 50-year-old patient with a history of blunt trauma to his left eye. He presented with 180-degree zonular dialysis with subluxated lens, a nuclear cataract, and 20/80 vision. I proceeded with a superior sclerocorneal incision. I used dispersive viscoelastic to tamponade the area of dialysis. I find it preferable to start the capsulorhexis in the quadrant that has the best zonular support, since it will be easier to puncture through the capsule in that area. You can see the folds that appear in the anterior capsule as I proceed with the rhexis. This is a typical sign of zonular weakness. Once I have completed about 90 degrees of the capsulorhexis, I insert the first capsular retractor in order to get more support and centration of the bag. I use small limber incisions to insert the hooks, trying to keep them quite vertical and short. I find this helps me maneuver the hooks more easily inside the eye. If the tunnel is too horizontal and long, it will be much more difficult to move and tilt the hooks in the proper position. Here I'm carefully completing the capsulorhexis. Now I'm inserting the final capsular retractor. You can see how we achieved a good centration of the lens and the capsulorhexis with this approach. I find the use of the retractors very helpful to avoid vitreous prolapse through the dialysis. Also, by keeping the posterior capsule tense and the capsular bag formed, they lessen the chances of posterior capsule rupture through phacoaspiration. Now I'm proceeding with a hydrodissection. This step is crucial to facilitate the prolapse of the heminucleus into the anterior chamber further on. I am now sculpting the groove for a stop and chop technique. A smooth and bimanual rotation of the nucleus to further deepen and elongate the groove. I am now cracking the nucleus in half and bringing one heminucleus up into the anterior chamber to chop it. I find it easier to start with the heminucleus where the zonule is stronger, thus allowing the other heminucleus to maintain the bag formed where the zonule is absent. Working outside the bag diminishes the chances of posterior capsule rupture in a case of zonular weakness. Once I have aspirated the first heminucleus, I rotate the remaining heminucleus towards the phaco tip. As you can see here, the nucleus might get stuck in one of the capsular retractors. For the final fragments, I lowered the aspiration rate. I am now inserting viscoelastic and loosening the capsular retractors to insert the capsular tension ring. I had a bit of a struggle to insert the capsular tension ring manually. Actually, the first time I released it, I saw it was headed towards the angle instead of the bag, so I had to recapture it and release it again, this time aiming in the correct direction. I am now removing the capsular bag retractors. For this patient, I opted for a 3-piece acrylic intraocular lens and inserted it inside the bag. Finally, I am aspirating the remaining viscoelastic and ensuring the incisions are properly sealed. This is a picture of the patient 24 hours post-surgery and 3 months after the surgery. As you can see, both the capsular axis and the IOL are perfectly centered. Thank you very much for your attention.